cardiomyolysis, which is characterized by myoglobinuria and acute kidney injury. So actually 70 to 80% of people tolerate statins well, and these are the something like 35% of patients who are suspected of statin intolerance, and out of these 20 to 30% do have symptoms, but the cause is something else, and only 5 to 6% of patients are actually statin intolerant. So this is the approach by Banach and Mikladis about four-step approach of how to approach SAMs. So the first step is to establish the temporal association between statin and onset of the symptoms. Usually 70% of in patients, symptoms occur within first 12 weeks, and in nearly 90%, symptoms occur within 6 months. So the patients who have been taking statins for many years and then they develop some muscle symptoms, they are usually not due to statins. The second step is to rule out other kinds of muscle aches and pains, which may be hypothyroidism, new intensive exercise, vitamin D deficiency, a concomitant use of some other drug that is increasing the levels of statins. The cardiac drugs which we use include ranolazine, amiodarone, and calcium channel blockers. So the third step is to apply the SAMS clinical index to identify patients whose muscle pain is because of statins. It has 4 criteria. The first is the location and pattern of the muscle symptoms. Statin-induced muscle disease usually involve the proximal muscles of the shoulders and hips. The second is the onset of symptoms. Onset occurring early after the statin initiation is likely because of statin. Then we have to see the effect of the statin withdrawal, whether or not the symptoms abate. And lastly, we re-challenge the patient with the same or some other statin and then see how quickly the patient again develops the symptoms. Based on the scoring systems, we can identify the patients who actually have SAMs. So then comes the approach in management. And for that, we have to first of all discuss with the patient the utility and importance of the statin use in prevention of the coronary artery disease and other vascular disorders. So shared decision is made, and it is basically made on the basis of the CK levels. If the CK levels are more than 4 times upper normal limits, then obviously we have to stop statins for at least 4 to 6 weeks. If the muscle pain is tolerable and CK level is less than 4, then statin can be used, but in lower dose. And if the muscle pain is intolerable, irrespective of the CK levels, again statins have to be stopped for some time, and alternative strategies may be employed. These strategies include switching between the statins, alternate day dosing, reducing the dose of the statin, and then we have the alternative agents. Regarding the alternative agents, these are the ACC guidelines for management of patients with statin intolerance. So when you label a patient with statin intolerance, patients should be intolerant to at least 2 statin, and out of these, 1 must be at the lowest dose, which is the Rasuva 5 or Atorva 10. So the first line agent for treating such patient with atherosclerotic coronary artery cerebrovascular disease, the first line is ezetimibe or PCSK9. Second line is bempedoic acid or inclisiran, and the third line is evenacumab. So these drugs are used for the patient for which the targets, LDL lowering target, are quite high. On the other side, those patients without atherosclerotic disease, but with other indication of statin and statin intolerance, the first line is ezetimibe, second is the bile acid sequestrant, and the third line is the bempedoic acid. So now 2 years have passed since the patient had primary PCI. He has been taking medicine regularly. Now he has heard someone in the community talk about that diabetes and memory loss is quite strongly associated with long-term usage of statin. So let's see these 2 points. So the normal physiological levels of statin, especially in certain indigenous population of even our world, is around 50 to 70. So the main issue is that our genetic makeup has remained same over last many years. However, our dietary lifestyle and our physical activities have drastically changed. So the myth of memory loss. We know that cholesterol is extremely important in the brain. There were certain initial studies which showed that the long-term usage of statin is associated with the memory loss, but they were mostly case reports. So this was the Fourier trial, which was for PCSK9, and this is the Abingos sub-study of this trial. It had more than 1,200 patients, which were given PCSK9 for nearly 19 months. LDL level were quite low, and these patients were followed for the development of any neurocognitive defects. And it was seen that There was no memory loss, no neurocognitive defects. So this study basically lays to rest the myth of memory loss with statin. And secondly, the blood-brain barrier uh, prevents uptake of cholesterol from the blood. So most of the cholesterol that is present in the central nervous system, that is formulated inside the brain itself. So statin and new onset diabetes mellitus. Patients on statin treatment have been shown to exhibit a dose-related response in developing type 2 diabetes. However, the number needed to cause one case of diabetes is 255 patients over 4 years of treatment. So when you compare it with the benefit of statins in these patients, the benefit certainly outlies this very minute risk of developing diabetes. So this is the scenario which has basically changed my practice over the last few years. So it's a 39-year-old female with a history of NSTEMI. He had PCI to LAD and circumflex and had been taking guideline-directed medical treatment for 2 years. Her latest LDL is 100 and now she has become pregnant. Historically, statins had been designated as category X compound. This was based on the understanding that statins block cholesterol synthesis in all cells and this may affect fetal morphogenesis. The combination of pathophysiological basis, the animal studies which showed teratogenic effect of statin, and early human case report led FDA to put in category X on this statins for pregnancy. However, we have two new types of data for statin usage in pregnancy. First is the accidental use of statins in pregnant females, and there are multiple meta-analyses. And when these patients were followed, even on statin, there were no fetal effect when adjusted for different confounding factor. Secondly, pravastatin, which is a which is a hydrophilic statin, this has been used in at least 4 different trials for the prevention of preeclampsia. Obviously, the trials were a bit negative and preeclampsia was not prevented, but this trial did show the benefits of the safety of pravastatin in pregnancy. So this led FDA to remove the category X designation for statin in 2021, and statin can be used in patients with familial hypercholesteremia and patients with prior atherosclerotic cardiovascular disease. So my patient, she probably will continue statin. Obviously, this is a bit controversial statement as well. We know the only pregnancy safe options are LDL apheresis and bile acid sequestrant, but they also must be used with vitamin K supplementation. So certain novel therapies now I'm going to quickly go through because I have lost some time with the lecturant issue. So first of all, we have the bempedoic acid, the drug which has been making waves in Pakistan these days. So this is basically an inhibitor of ATP citrate lyase, which is a step in the cholesterol mechanism upstream of the HMG-CoA reductase. The dosage is 180 milligram once daily with or without food. So why bempedoic acid does not cause myopathy? So bempedoic acid is a prodrug. It is converted by acyl-CoA synthase enzyme into an active compound, and this compound then inhibits the ATP citrate lyase. Obviously, this step is upstream to the HMG-CoA reductase. The effect will be that the less cholesterol will be formed. So this acyl-CoA synthase enzyme, this enzyme is not present inside the muscles. So this compound, the bempedoic acid, is not activated inside the muscles, and myopathy doesn't occur. It can reduce LDL by 17 to 18%, and combination of zitamib with bempedoic acid are very good for patients with SAMs. It reduces LDL by up to 38%. So that gives us some option for managing these patients. There were two trials, Clear Serenity trial, Clear Outcome study. Clear Outcome study was the first study which has shown that in patients with statin intolerance and without statins, bempedoic acid not only reduces LDL, but it also reduces cardiovascular outcome. A recent study published last year, so likely this will change guidelines in future. Two warnings, bempedoic acid can lead to extreme elevation of uric acid and can precipitate acute gout, and it is also associated with the tendon ruptures. So then we have the PCSK9 inhibitors. Obviously, because of cost issues, they are not available in Pakistan. So what they do is that PCSK9 combines with the LDL receptors, and these receptors are internalized and degraded. So when we have the PCSK9 inhibitor,